Hi, I'm Dr. Ann Peters, and it's good to meet all of you, even though I'm remote. And today I'm going to discuss adjunctive therapy for people with type 1 diabetes. These are my disclosures of potential conflicts of interest, and these are my objectives. First, I'm going to discuss the need for non-insulin therapy in people with type 1 diabetes. Next, I'm going to review the literature on glycemic effects of SGLT inhibitors and GLP-1 receptor agonists in people with type 1 diabetes. And then I'm going to consider the non-glycemic benefits of these agents, which is part of the reason why I think it may be useful to use them in our patients. So first off, why do we need adjunctive therapy? Well, we need adjunctive therapy in our patients with type 1 diabetes because they're not reaching their targets. And these are data from the Type 1 Exchange QI Collaborative of over 12,000 adults with type 1 diabetes who are treated in the best diabetes centers in the United States. So this is the best we can do. And the best we can do is approximately a third of patients reaching their goal of an A1C of less than 7%, and the vast majority well above that A1C target. So clearly, we're not meeting targets with insulin therapy alone. The other reason, though, that we need adjunctive therapy is because insulin is so imperfect when administered exogenously. And you can see this, which is a tracing for one of my patients. She's a woman in her early 60s. She has type 1 diabetes. She's on multiple daily insulin injections, and she has an exceedingly high level of diabetes distress. She feels like she can, quote, never get it right. Her glucose levels are either high or low. They're rarely in range, and she feels like she's fighting her diabetes all the time. And I think it'd be great to be able to give her something that evened out these ups and downs and improved the quality of her life. And frankly, I'd love to someday take insulin away as a requirement altogether, but that's a much more far flung dream, but hopefully it will happen someday. So, in terms of available non insulin therapies for people with type 1 diabetes, there's only one that's on label, and that is pramlintide, which is synthetic amylin. And it's an agent that has to be given by injection, a separate injection from insulin, and it has to be given along with the insulin 3 times a day before meals. Most of my patients who tried this in the past didn't see much benefit. And frankly, the majority aren't using it. I think I have one or two patients who still use pramlintide, but the hassle factor seemed too great relative to the benefit. So most of my patients who use non-insulin therapy are using off-label agents. Now remember throughout this talk that when I discuss any of these agents for use in people with type 1 diabetes, that it's an off-label use. But we have metformin, SGLT2 inhibitors, and GLP-1 receptor agonists. Now I'm only going to touch briefly on metformin, largely because it doesn't do a lot in terms of glycemic control in people with type 1 diabetes. I do think, as a separate topic, that it does help women, whether they have type 1 diabetes or not, with PCOS. So if I have a patient with type 1 diabetes and PCOS, I may prescribe metformin. It does reduce insulin requirements to some degree and limit weight gain. But again, you don't see a big weight loss and you don't see a big reduction in glycemia. It's a small change. And so metformin as an agent that I use often in my patients with type 1 diabetes, it really isn't high on my list. Now, you could ask me, what about patients with metabolic syndrome and type 1 diabetes? And in that case, again, I might use metformin, but I'm more likely to use an SGLT2 inhibitor or a GLP-1 receptor agonist. And the reason I'm more likely to use those two agents is because they do provide better improvements in glycemic control, in weight loss, and they have non-glycemic benefits, as we all know, in terms of cardiovascular risk reduction, impact on heart failure, and on CKD. So I've been leaning more in recent history to use SGLT2 inhibitors and GLP-1 receptor agonists. So I'm going to show you a case, the first patient in whom I used an SGLT2 inhibitor, and follow her through the course of the past several years. So this is my first patient that I ever started on an SGLT2 inhibitor. And this was right when these agents first came on the market. And this patient is very smart, and she did her homework, and she came to me and she said, I've reviewed the mechanism of action for SGLT2 inhibitors, and I really think that they could help me. Their mechanism of action is independent of beta cell function, and therefore it could help lower my glucose levels. And there is some weight loss, and this is a patient who was having a lot of issues with her weight. And this is what her first tracings look like. These are finger sticks. And you can see she's all over the map. Her glucose levels are often high. There's not that much that's in range, and her A1C is 9%. So I basically said to her, we've never done this before. It's completely off label, but let's give it a try. Now, this is before we knew of the risk of DKA. This is way before. So I wasn't that worried, and I thought this could work. This could help her. So I started her on 100 milligrams of canagliflozin and up titrated to 300 milligrams. And this is what her glucose levels looked like afterwards. And you can see that they're much lower, they're much more time in range, there's much less variability. And this is something that the patient was very happy with. I think she changed her lifestyle somewhat, but it was a phenomenal improvement in her glycemic levels and basically how she felt. These are her individual tracings. This is before she went on the canagliflozin, and she was trying. You can see that her glucose levels here are mostly above target. You can see if you look at that lower line of her insulin doses that she's giving dual waves with the pump, which means that she's giving a bolus first and then extending the second part of the bolus over time. And she's really trying here, but again, she can't get her glucose levels in range. This is what happens the day she started on canagliflozin. And you can see the arrow is when she took the first dose. And her glucose levels not only come down spectacularly, you can see that she needs a lot less insulin throughout the day. Now, I do believe that canagliflozin helped. I also think she probably ate differently this day. It's a little bit difficult to always tell what's what with people who are giving insulin. But regardless, this led to a big benefit over time in her glucose levels. But then we found out that there was this increased risk for diabetic ketoacidosis. And I actually was walking across the street in San Diego and ran into a dear colleague of mine, Dr. Earl Hirsch, and we were discussing how odd it was that we were seeing so many patients in DKA, because in our practices, we didn't see that much DKA historically. And I thought maybe that there was a weird virus out. This was way before COVID. And that maybe this was causing people to go into DKA in rates that we hadn't seen before. But then we talked to a number of colleagues around the country, and we found out that everybody was seeing this in patients who were on an SGLT2 inhibitor along with insulin who had type 1 diabetes. So we wrote the first case series of these patients, And this included people with both type 1 and type 2 diabetes. And we then began a long journey because we were working closely with the FDA to understand this and to figure out who was and wasn't at risk. And the risk of DKA is really primarily with people with type 1 diabetes and insulin deficient people with type 2 diabetes. And then there's this class of people that we call LADA, who have latent autoimmune diabetes of the adult, who are getting type 1. And those are people who are also at higher risk because they're becoming insulin deficient. So we wrote about this, and then we decided to talk to our patients about it. And I warned this first patient of mine about this risk. So about 1 year after she was on the canagliflozin, she develops pneumonia. And even though warned of the risk of euglycemic DKA and told to check for ketones and told to stop the canagliflozin if she got sick, she seemed to forget all of my advice. And when she got sick, she was basically home alone. Her husband was out on a business trip. She sat in her house, ate very little, and continued to take the canagliflozin. She then went in to very significant euglycemic DKA. So in DKA, her glucose level was about 138. Her pH was 6.9. She was really sick. She hadn't had DKA since she was 5 years old and was diagnosed with type 1 diabetes. So this really got me because I knew that I'd warned her, but clearly I hadn't warned her effectively. And this is somebody who was really quite savvy about her diabetes, and even still, she went into DKA. So I said, no more canagliflozin. So this is the very same patient who was doing so beautifully. Now her glucose levels are all out of whack again. They're very high, and she's pretty miserable. And over the course of a month, she begs me to go back on canagliflozin. And I'm much more shaken up by her about the risk here for DKA because she was really sick. And yet I decided, okay, I'll try, but I'll give her a lot more education and I'll put her on a lower dose. I'll put her on just 100 milligrams and really not up titrate from there. So this is what happens when she's back on canagliflozin, 100 milligrams per day. And her glucose levels are again much better. The postprandials are much better. In this particular tracing, she's actually going low at around 2 p.m. and then having a rebound high because she's exercising. But her time in range is much better, and she's just really doing better. So she really feels that canagliflozin is helpful and that she can manage the risk. So here she is after 9 years on canagliflozin. It's December 2022, and she's had 2 episodes of DKA. That first one I just discussed, and a second one where I can't tell if it was entirely due to the canagliflozin, but it certainly didn't help. She was on an airplane. Her catheter came out undone from under the skin, and she basically was without insulin for 5 or 6 hours as she flew across the country. By the time she got off the plane, she was already in DKA. She then consumed carbohydrates and gave insulin as I taught her to do. She got somewhat better. She and her husband went to their hotel room. She reinserted another cannula and restarted the pump. But basically, that failed as well. And overnight, she basically got no insulin. And she ended up in DKA again that required hospitalization. But I'm not sure that she wouldn't have gone into DKA anyway, but I certainly think that being on canagliflozin lowered that threshold. But this is what her tracings look like. You can see that she remains well controlled. She's much of the time in range. Her A1C is in the high 6s, and she has some postprandial hyperglycemia, but so much better than it was without canagliflozin. But here she says to me that her husband, who's about 150 pounds overweight, had gone on semaglutide for weight loss. And she's about 40 pounds overweight. And she says, why can't I try going on semaglutide once a week? So I start her on a very low dose and I up titrate. And when I use semaglutide off label, I generally don't go above 0.5 milligrams per week. And here you can see the combination of the two. This is in June of 2023. She's on canagliflozin and semaglutide and her insulin pump. And her time in range, which generally was in the 70% range, is now up to 84%. Her A1C is, say, 6.5%. She's doing great, and she's lost about 20 pounds. Now, here, I finally say, can't we just stop the canagliflozin? I don't really know what additional benefit there is, and I hate the risk for DKA. And to be fair, I can't take away the risk of DKA with an SGLT2 inhibitor completely. That risk still persists in spite of my best efforts. So I finally get her to stop the canagliflozin. So here she is last July. She's on semaglutide alone. She stopped the canagliflozin. And arguably, her glycemic control is a bit worse. Her variability's gone up. Her postprandial glucose levels have gone up. Her time in range has gone down, and her average glucose is higher. On the other hand, I think I've largely eliminated the risk of DKA, and I think she's doing well on semaglutide alone. Now, she's a woman in her 40s. She does not have cardiovascular disease. Importantly, she does not have kidney disease. So I'm very happy with this, and she's happy with this. And so I think we're going to proceed with insulin plus a once weekly semaglutide injection. So that's my patient number 1. And I'm going to review with you some of the data for SGLT inhibitor use in people with type 1 diabetes. And there were 3 phase 3 trials that were done. One was with dapagliflozin, one was with empagliflozin, and one is with sotagliflozin, which is an SGLT1/2 inhibitor. And this slide says not yet approved for any indication, and it's been subsequently approved for a heart failure indication by the FDA, but not for type 1 diabetes. So in these trials, they had a fair number of patients. So between 782 and 1,400 patients, that's a lot of people for a type 1 trial. And they basically randomized patients to varying doses of the agents. And the risk for DKA is, in fact, dose related. And in the EASE trials with empagliflozin, they used the very lowest dose of empagliflozin, which was 2.5 milligrams. And then they used 10 milligrams, 25 milligrams in placebo. All of these randomized controlled trials compared the active agent to placebo. And so we have a fairly good sense of how they work in people with type 1 diabetes. Now, this is an illustration of what happened in these trials. And it's not a meta-analysis, it's just sort of a general summary. But basically, A1C levels fell by around 0.4%. So not a huge A1C reduction, but in trials with type 1 diabetes, that's reasonable. There was a fall in fasting glucose levels and in postprandial glucose. There was a fall in body weight, which was only 1 to 2 kilograms, not a lot, but it certainly wasn't an increase as we're improving glycemic control. And there was a reduction in blood pressure. And what I didn't say in the first patient that I discussed was that she had been sort of borderline hypertensive before she was started on canagliflozin, and her blood pressure readings became very normal on the canagliflozin, so she didn't need additional therapy. As we know with these agents, there's an increase in genital mycotic infections, and in some of the trials there was an increase in UTIs and in others not. There was, in all of these studies, an increase in the risk for DKA with an increasing dose of the SGLT2 or SGLT1/2 inhibitor. And this happened no matter what was done to reduce the risk. But I must say that these trials actually began before we really knew of the risk. So there weren't good protocols for reducing the risk for DKA. And there was no increase or decrease in rates of severe hypoglycemia. Now, just to illustrate the change in A1C, these are data from the EASE trials with empagliflozin. And this looks at A1C levels over time, and this trial goes on for a year. And interestingly, just like in the trials with people with type 2 diabetes, there's no difference between the two doses, the 10 milligram dose and the 25 milligram dose, in terms of glycemic effect. In these trials, just like in all trials with people with type 1 diabetes, having a study coordinator adjusting your insulin improves glycemic control. So these patients started out with an A1C of 8.6 and came down to around 8. And then on the active agent, they fell down to the mid 7s. And you can see that that persisted more or less throughout the trial. Now, the bottom graph looks at that lower dose of empagliflozin, the 2.5 milligram dose. And you can see with that lower dose, there's clearly less of an improvement in glucose levels. There still is a little bit of improvement, but less. And this is one of the reasons that the 2.5 milligram dose did not get chosen for distribution, because the reduction in A1C was just too small and the other benefits appeared to be mitigated, even though, as I'll show you, the risk for DKA was reduced. The real reason that I loved these agents in my patients with type 1 diabetes is because the patient-reported outcomes improved so much. And the green in these graphs is the placebo response, and the blue colors are the dose responses on the canagliflozin. And it turns out that in clinical trials, you never get this kind of consistent improvement in satisfaction and just feeling better on the agent. It just isn't found. And patients not only felt better, they felt that they were more in control of their hyperglycemia, and they actually felt that they spent less time in hypoglycemia. So the patients, like my first patient, loved being on these agents. And I still have patients who, since this began, are still on their SGLT2 inhibitor because of the fact that it makes their control better and it makes them feel better. And I think that's very important because it's so hard to have type 1 diabetes. This looks at the incidence of DKA in all three of these trial series. And you can see that in every case, save one, the incidence of DKA was higher in the patients on treatment. And so that was true for dapagliflozin, for empagliflozin, and for sotagliflozin, except for that 2.5 milligram dose of empagliflozin. So that very, very low dose didn't seem to increase the risk for DKA, but it didn't do much in terms of improvements in glycemic control. So when I started using these, I started at the max dose, and then I quickly decided to use submax doses because I felt that I could reduce the risk of DKA to some degree. And the other thing is that most of the DKA happened in women, and most of the DKA happens in women who are on insulin pumps. Because I think that the insulin pump, by infusing rapid-acting insulin, doesn't give enough insulin depot into the body to prevent DKA from occurring when patients are on these agents. So in my experience, I've never had a patient go into DKA who was on multiple daily insulin injections using an SGLT2 inhibitor, although I've obviously had people on an insulin pump having a problem. So as I said, the original trials didn't really have protocols for preventing DKA because they started before we knew of the risk. So in all of these trials, they had a fairly wide range for inclusion. They had A1Cs that ranged up to 11%. Well, when I made my own protocol for this, I really thought that if someone with type 1 diabetes had an A1C above 9, that they weren't giving enough insulin. And if you're not giving enough insulin, you're at an increased risk for DKA. So when I started my patients on an SGLT2 inhibitor after I knew of the risk, I made sure that I basically optimized their insulin regimen and got their A1Cs down to less than 9 before I started it. I then measure baseline ketones, and I prefer if people can do a fingerstick ketone level, but if not, I'll use the urine results. But I basically exclude people who have baseline positive levels, elevated levels of beta hydroxybutyrate in the blood or urine ketones, because I don't want somebody who's under insulinized. And then I try to get them a meter so that they can measure their fingerstick beta hydroxybutyrate levels. And what I do when I start somebody is I get a baseline. I make sure that they know how to test their ketone levels. I make sure that they're used to it. And I have them check in the morning just for standardization. And I do that for about 2 weeks to be sure someone isn't ketotic in their regular life. And then I'll start a teeny tiny dose of an SGLT2 inhibitor and go up slowly and have them keep checking their ketones. If their ketones go up too much on the agent, I'll stop it. But if they don't, I'll continue it with guidelines of when to check their ketone levels and when to stop the agent. Now, this is a paper that was published about 2 years ago in which Charles Alexander, author, decided to get those of us who frequently used SGLT2 inhibitors in patients with type 1 diabetes to write down our protocols. And this was published in Diabetes Spectrum. So you can see that each one of us has a different protocol for trying to reduce the risk for DKA. But nonetheless, we all have a protocol that we discuss with our patients and make sure that they understand it. And I won't do this in patients who can't really grasp the idea of ketone testing and what that might mean, because I don't want to put people into DKA. So now moving on to using GLP-1 receptor agonists in these patients with type 1 diabetes, at least those who are overweight and or obese. Now I also want to tell you in all honesty that during the pandemic, I stopped starting SGLT2 inhibitors in my patients with type 1 diabetes because things were bad enough with COVID and I didn't want to cause patients to go into DKA because I was trying to keep people out of the hospital. And in fact, I tried to stop the SGLT2 inhibitors in my patients with type 1 diabetes because I was trying to keep everybody safe. I still had patients who stayed on them, and we're going to talk about the use of these agents in patients with diabetic kidney disease because those are people in whom I would start an SGLT2 inhibitor for renal protection. But for most patients, I switched to using GLP-1 receptor agonists. And I'm going to show you why and basically how these agents have been really helpful in the management of my patients with type 1 diabetes. And again, I'll keep stressing this is an off-label use. So first off, we know that having type 1 diabetes doesn't prevent you from becoming overweight and obese. And as our entire country has become more overweight and obese, our patients with type 1 diabetes have suffered the same phenomena. And so we know that these rates are high, and many of our patients with type 1 diabetes are going to be overweight or obese. We know that in everybody, obesity is associated with many other disease states. It's not just being overweight, it's the fact that there's all sorts of consequences from non-alcoholic fatty liver disease to coronary heart disease to sleep apnea to all sorts of different malignancies. I really feel that it's important to think about treating obesity, and the American Diabetes Association has really changed in terms of their focus. And now that we have agents that can help reduce weight, this has become a real focus, I think, of the practice of treating type 2 diabetes and in my world, treating type 1 diabetes. Another issue for people with type 1 diabetes is that they have a markedly increased risk for cardiovascular disease. This is a study of over 35,000 individuals with type 1 diabetes, and they have an increased risk for dying from cardiovascular disease or being hospitalized for cardiovascular disease compared to matched controls. And although this gets less over time as we've been better at treating cardiovascular risk factors, it still remains high. In addition, our patients with type 1 diabetes have a markedly increased risk for hospitalization for stroke and heart failure. So our patients need as much as we can do for them to reduce these risks. These are data from the STEP trials, which look at higher dose semaglutide in patients with obesity. And basically, what we found is that in patients without type 2 diabetes, these drugs are excellent as weight loss drugs. In the STEP 2 trial, they looked at weight management in people with type 2 diabetes, but in the other STEP trials, it was with people without diabetes, which makes me think, obviously, that semaglutide would work in people with type 1 diabetes who have obesity. And interestingly, if you look at the label for the 3 milligram dose of liraglutide or the semaglutide 2.4 milligram dose, and all of the doses that are less than that, they actually don't have a contraindication to type 1 diabetes. They basically say that these agents are useful for weight loss in anybody, and in particular, if they have one weight-related comorbid condition like type 2 diabetes, but they don't exclude people with type 1 diabetes. So theoretically, if you use semaglutide or liraglutide in somebody with type 1 diabetes, it's not really an off-label use because it's not contraindicated in the label. So I guess it is an off-label use, but the FDA, with whom I have spoken, says that we physicians can use medications in any way we think is safe and good for the patient as long as we document the indication for their use and the fact that we've discussed with the patient that it is in fact off-label. So a number of years ago, the companies that make GLP-1 receptor agonists were studying them in people with type 1 diabetes to see if they worked. And basically what they found, and this is a study done with liraglutide, was that there was no significant reduction in A1C, but there was more weight loss. But this was back in the day when A1C was the only target benefit. It was the primary endpoint in these trials. And because that did not reach significance at 24 weeks, the company did not continue to pursue this indication. And basically, no one is doing it. There are some investigator-initiated trials where they're looking at this, but this is not being studied in a large number of people with type 1 diabetes, even though many of us are using these agents in our patients with type 1 diabetes. Now, there is some data that's come out of the trials that were done, and this was interesting to me because this looked at the efficacy and safety of liraglutide in people with type 1 diabetes based on baseline characteristics. And what the investigators found was that although there wasn't an overall significant reduction in A1C, that people who had residual C-peptide levels, where they had measurable C-peptide levels, that they're the ones who did actually have a more favorable response in terms of A1C. And that makes sense because these patients can respond to the effect of the GLP-1 receptor agonists on their beta cells, and it showed a positive benefit. In terms of risk, this is an interesting risk to look at. which is, does a GLP-1 receptor agonist in slowing gastric emptying reduce the ability of a patient to recover from hypoglycemia? So the thought was, is if somebody was low and they drank some juice, that maybe because of this delay in gastric emptying, that the absorption of the carbohydrate wouldn't happen quickly enough and the person would remain hypoglycemic. But that didn't happen. And so when they did the analysis, they did not find a slowing in terms of glycemic recovery. And the gastric slowing probably doesn't persist over much longer than a month or two. So it didn't seem to interfere with recovery from hypoglycemia, which is comforting, I think, to those of us using these agents. So let me tell you about some patients. This is a very detail-oriented patient of mine. He's on semaglutide. He's had type 1 diabetes for many years and has actually really struggled with his diabetes. You'd think an economist would be numeric, but he's the kind of person who's incredibly busy and doesn't really want to think about carb counting and dosing, and has struggled, has a fairly high degree of diabetes distress. So he went on semaglutide, and I started him out on a low dose and up titrated. I think he's only on 0.5 at this moment. And he sent me this email. He said, "Here is a brief summary of my response. My average CGM glucose level fell by 15%. My basal insulin use went down by 25%. And my total daily insulin dose was down by 33%, and my time in range was up 16 percentage points in absolute terms." I rather love patients who analyze their data like this. But you can see in his table, his average CGM reading went from 172 to 149. His total daily insulin use went from 49 to 32 units. And his time in range went from 61% to 77%. And then he said, "I didn't have a scale until recently, but I think I lost about 8 pounds." And this looks at his glucose levels. And on the top is what his data looked like before. And he's on a hybrid closed loop system. And you can see that the hybrid closed loop system almost always brings him down overnight, and that's on the left-hand side of the graph. But he always would go up after eating. And again, he had issues focusing on carb counting and dosing before he ate, which is always hard for people with type 1 diabetes, that mealtime dose and getting their after eating glucose levels down. And look at the below graph. This is after 2 months, and his glucose levels are much more in range. The overnight is good, the days are good, he's really feeling better, and his A1C has come down, and I'm just really happy at this result. But mostly I'm happy with this result because he's so happy with this result, because it's resulted in improved glycemic control and weight loss, and frankly, it's made his diabetes management feel easier because the drive to eat all the time is less. He's not snacking at night, and the semaglutide is really sort of helping modulate his food intake. So this is the kind of result I see often when I add in semaglutide to the treatment of my patients with type 1 diabetes. And I'm going to show you one more patient. This is a patient of mine on Loop, which is a do-it-yourself management system for type 1 diabetes. So Loop itself is off-label. And this is the best she can do. And she's trying really hard. Her time in range is about 63%. Her average glucose is 156. And she does, like everybody on all of these automated insulin delivery systems, comes down at night, but the days are still more variable because of postprandial glucose excursions. So her coefficient of variation here is 32%, and her GMI, her calculated A1C, is 7. She had maybe 30 pounds to lose to come down to reasonable BMI. And this is after 6 months. So you can see now, again, like that first patient, she loses weight. She's lost 20 pounds. Her glucose levels are now much more in target range, and there is much less variability. And this shows you her AGP report. She's gone from, say, a time in range of 60 something percent to a time in range of 94%. She's very rarely high. Here she has 2% low, so I'd like to reduce that a bit. But her glucose management indicator, her GMI, is 6.2. Her measured A1C was 6.4%, and her glucose variability has gone down from 31% down to 25%. And she's just doing remarkably well. So again, in this case, a GLP-1 receptor agonist worked well. It helped her glucose levels go down. It helped her lose weight. And it really improved the quality of her life. And both of these patients are completely insulin deficient. These aren't patients who have measurable C-peptide. So this was all based on the impact of the GLP-1 receptor agonist on behavior, snacking less, feeling less hungry, as well as helping reduce caloric consumption and causing weight loss and a reduction in their insulin requirements. So we all know that SGLT2 inhibitors and GLP-1 receptor agonists also have non-glycemic benefits. And these have been increasingly elucidated in terms of clinical trials data and have also been shown to be true for people with both type 1 and type 2 diabetes. So these are heart failure outcomes in people with type 2 diabetes and without type 2 diabetes on SGLT2 inhibitors. And the top part of this table looks at the outcomes in people with diabetes and the bottom part without. And my feeling is if it works in people without type 2, it doesn't require that someone have type 2 for a benefit. Therefore, someone with type 1 diabetes should also benefit. But we certainly don't have trials in heart failure in people with type 1 diabetes, even though there's an occasional patient that's in these studies. Perhaps even more importantly, in my patients with type 1 diabetes is the notion that SGLT2 inhibitors improve renal outcomes. So we know from all of the trials that they basically slow the decline in eGFR. They reduce progression to end-stage kidney disease and even renal death. And remember that in all these trials, these patients had well-controlled blood pressure. They were on an ACE inhibitor or an ARB, so the SGLT2 inhibitor was already added to state-of-the-art care. But this was really impressive to me, what we can do in terms of helping people stop the fall in their renal deterioration and avoid dialysis. Now, does this work in people without type 2 diabetes? And yes, we know that it does. And there are actual hints that it also works in people with type 1 diabetes. And again, I don't see why it shouldn't, except for we don't have the data. We do have a little bit of data on the benefit of an SGLT2 inhibitor on renal function in patients with type 1 diabetes. So these are data from the EASE trial looking at empagliflozin, and the results are from patients who started the trial with an urine albumin creatinine ratio of greater than 30. And what you see, the brown are the placebo-treated patients, and the green and the blue are patients on empagliflozin. And you can see that there's a reduction in the fall of renal function. So these patients do better. Their progression of renal failure is improved on the empagliflozin. Now, this was neither long enough nor big enough to really make any conclusions, but it's certainly suggestive that there's an improvement in albuminuria with these drugs in people with type 1 diabetes as well as people with type 2 diabetes and in those without diabetes. Now to move to the GLP-1 receptor agonists, we know that in people with type 2 diabetes, there's an improvement in cardiovascular outcomes, as shown here in this forest plot, in terms of improvement in a 3-point MACE. Now, this wasn't found in all the trials, but in the majority of the trials, there was benefit, particularly if you followed people out over time. We do have some real-world data of the use of GLP-1 receptor agonists and SGLT2 inhibitors in people with type 1 diabetes, and this comes from the University of Texas Southwestern Medical Center. And in their database, they found that both agents reduced the A1C pretty similarly, down from the high 7s to 7.3. That there was weight loss, but the significant weight loss occurred with GLP-1 receptor agonists. There was a non-significant weight loss with SGLT2 inhibitors, and that the total daily insulin dose didn't go down really with the SGLT2 inhibitors, but did go down with the GLP-1 receptor agonists. And obviously, this is because of the weight loss. Those people on the GLP-1 receptor agonist were thinner, and therefore it needed less insulin. However, if you look at the same database, there was, not unexpectedly, an increase in the risk for DKA with the SGLT2 inhibitors compared to the GLP-1 receptor agonists. So again, this risk for DKA exists throughout, no matter what we do or how we try to prepare patients to deal with it. This is data recently published in obesity looking at the combination of a GLP-1 receptor agonist and an SGLT2 inhibitor in people with type 1 diabetes. And you can see that the combination of the two resulted in the best weight loss and the greatest reduction in A1C. So from what I've shown you clinically, as well as what the data has shown, these agents are effective, they work differently, and they have different risks, particularly the risk for DKA with SGLT2 inhibitors. So why use SGLT2 inhibitors in people with type 1 diabetes? Well, people really like it. It improves their quality of life and their high levels of patient satisfaction. You get some reduction in A1C, a little bit of weight loss, and a reduction in glycemic variability, all of which is good. But I think the thing that drives me these days is because of the potential benefits in terms of CKD, heart failure, and cardiovascular disease. And in particular, for my patients with significant albuminuria who are already maximized on their other agents, I really consider using an SGLT2 inhibitor as long as I can mitigate the risk for DKA. Again, I'm not sure I can completely make that risk go down to zero, but I can do a lot to try to reduce it. So this is a slide for how I use SGLT2 inhibitors as safely as possible. And some of this I said before. I make sure that the A1C is less than 9 before I start, and that they don't have ketones before starting. I have patients check their ketones in advance before I started to show me that their ketones are negative and they know what to do. And then I take the lowest pill size of whatever the SGLT2 inhibitor I'm using is and cut it in half. So they're on a very low dose. I don't anticipatorily reduce insulin doses until glucose levels start to come down because I don't want somebody to be insulinopenic. And generally, I'll see a gradual reduction in the pre-meal doses as I see the impact of the SGLT2 inhibitor. I keep patients ketone testing until they're stabilized on their target dose. And then I make sure patients know to test their ketones if they feel sick or they change their activity or diet. I've had patients go on ketogenic diets on an SGLT2 inhibitor who went into DKA. I make sure that patients know if they have ketones that what they want to do is consume carbs and give insulin. That's how you help reduce the ketones and reduce the risk for DKA. I also make sure that patients have antiemetic treatment at home so that they can continue to consume carbs and fluids. and obviously go to an emergency department for care if they can't keep down carbohydrates. Now, I also know that patients on insulin pump therapy may be more at risk for DKA. So if a patient's on a pump, I'll have them give injected insulin if they're going into DKA or have mild ketones, because that way I'm sure that they're getting the insulin and I'm hopefully reducing their risk. So why use GLP-1 receptor agonists in people with type 1 diabetes? Again, patients really have a reduction in diabetes distress, and they really feel that they benefit from these drugs. They can have weight loss, in some cases fairly significant weight loss, but most importantly, they feel like they're being successful. Their glucose levels are coming down, they're losing weight, they're feeling good, they're feeling in more control. And so you may well see improvements in glycemia. I often do. And then there may well be benefit in people with cardiovascular disease in terms of cardiovascular risk reduction. So this is how I use GLP-1 receptor agonists in people with type 1 diabetes. We know GI side effects are common, and I tend to see them more in patients with longer duration type 1 diabetes, probably because there's some element of gastric slowing. I don't start on a dose that's on the pen. I start on clicks. So I'll give 2 to 4 clicks of semaglutide, and I only go up by clicks every week. And I don't go up if there are any GI side effects, and sometimes I'll decrease. But if I go up really slowly and it takes a person 3 months to get to 0.25, that's fine because they're tolerating it. And then I might be able to go up a little bit faster. And I generally don't use more than 0.5, although I have gone up to 1 milligram. But I generally don't need more than 0.5 milligrams per week because patients have weight loss with that dose and they have an improvement in their A1Cs and it just works. But again, start as low as you can and go up really slowly so people don't develop GI side effects. I don't reduce the insulin in advance because I'm going up so slowly, but I do have patients carb count and adjust and correct as they would normally. And generally, people will just by nature reduce their insulin, or I'll change the settings on their pump as they lose more weight. And as I said, in people with type 1 diabetes, I don't tend to go up much above 0.5. I've gone up to 0.1 and to 2 milligrams maybe once or twice with people who have significant obesity. So in summary, SGLT2 inhibitors and GLP-1 receptor agonists may be beneficial in people with type 1 diabetes for both glycemic and non-glycemic reasons. Because of the increased risk for DKA in individuals with type 1 diabetes on SGLT2 inhibitors, I generally use SGLT2 inhibitors for non-glycemic reasons, and that's generally because of diabetic kidney disease and potentially for heart failure. So I really think that we have to think about the patients, what we think might benefit them, and then choose the appropriate adjunctive therapy. And for now, and probably for the foreseeable future, these are going to be off-label, but that doesn't mean that they don't improve outcomes. Thank you for listening, and I'll now be live answering your questions.
All right, mic runners, does anyone have any questions for Dr. Peters? Okay, question coming up here.
Hi. Yes. What kind of dietary counseling do you recommend for your patients on type 1 when you start GLP-1? So I assume you tell them not to do the keto diet, or are there special dietary concerns?
Well, with SGLT2 inhibitors, you need them to eat enough carbohydrates so they don't become ketotic. So I work with them, my dietitian works with them, and you can always tell if somebody's on enough carbohydrate because you just measure their ketones. And if someone is ketotic, that means they're not on enough. So I do sort of the individual evaluation, but in general, I try to keep all of my patients with type 1 on a diet that's some odd combination of like paleo and Mediterranean, because I think it's really good, obviously, for them to get complex carbs, for them to eat higher quality protein, for them to try to not eat, refined carbs, rice, pasta, whatever, but recognizing that people want to eat those things, so you want to try to balance it in the diet. But I just try to make sure they're getting enough carbohydrate. If they're going to be on an SGLT2 inhibitor with a GLP-1 receptor agonist, we just work on stressing a healthier diet. But it makes it easier for them to eat better, I think, because their desire to snack is less, and it mitigates that hunger you get from insulin.
Thanks, Dr. Peters. I think we have a question at the back of the room, and then I'll come back to you, Teresa.
I've been having a difficult time getting insurance coverage for GLP-1 agonists with type 1. Do you have any tips or tricks?
Well, so this is the deal. I always think about the whole person, right? And these people with type 1 are also probably type 2, we just don't know it. But what I mean by that is they have insulin resistance. So if they're overweight or obese, so I double code, and I double code them all for type 1 and type 2. And if I do that, then I can usually get it covered. And if you have a patient whose BMI is greater than 35 or 40, you can actually get Wegovy covered for just weight loss. But I do double code, and that's what most of us do, is to make sure that somebody is E11.0 as well as E10.0, whatever the numbers after the decimal point are. So that works. And then sometimes it doesn't, but I've actually asked people who are the head of insurance companies, and they say, we don't know. If you think the person has type 1 and type 2, then that's what they have. And so I just call it double diabetes, but that's how I do it.
All right, Dr. Peters, I don't think you can see the room, but you have blown people's minds. They're so excited about this idea, I can just tell. Teresa, did you have a question over there?
She had the same question as the woman in
But
the back.
it's just, can I say one thing? It's just ironic because I was just on a call with a panel of experts who were speaking at some meeting, and all of us do that same thing about double coding. So it's not even just me being wacky. It's what we all do out here. This was somebody from the Barbara Davis Center and somebody from San Francisco, and everybody just double codes, and it works.
Yeah, I mean, I can see the logic in it, but I don't think, maybe I'm the only one who hadn't thought of that, but it's genius. And I feel like in the audience, the response was like, I could see the minds being blown. You've just given lots of people access to things their patients probably didn't have access to a few minutes ago. Okay, it is 10:15, and I do not see another question. So it is time for our activity break. Thank you so much, Dr. Peters, for joining us.
Thank you, guys. Take care. I wish I was there. Bye. Bye.